Hey there, everyone. We go on to part 6 of Regional Orthopedic Anesthesia for the ABA Advanced Exam. In this relatively shorter lecture, we're going to cover the ankle block, and I added a couple extra keywords that show up on the content outline related to fat embolism and tourniquet physiology. In talking about the ankle block, which of the following correctly characterize the relationship of the distal lower extremity nerves and the Achilles tendon? Posterior tibial nerve medial to the Achilles tendon, sural nerve lateral. Posterior tibial nerve lateral to the Achilles tendon, sural nerve medial. Posterior tibial nerve medial to the Achilles tendon, peroneal nerve lateral. And posterior tibial nerve lateral to the Achilles tendon, peroneal nerve medial. So the correct answer is going to be A, and you'll see this in an image coming up about the relationships of the distal terminal nerves in the ankle level. So the two nerves that straddle the Achilles tendon, as you might guess from that previous question, are the tibial nerve and the sural nerve. Okay, so 4 of the 5 individual nerves that can be blocked at the ankle derive from the sciatic nerve. The one exception is, of course, the saphenous nerve, which comes from the femoral innervation. Posterior tibial nerve, sural nerve, superficial peroneal, and deep peroneal branches come from the sciatic. Okay. Sciatic nerve divides at or above the apex of the popliteal fossa to form the common peroneal and tibial nerves. Common peroneal nerve descends laterally around the head of the fibula, where it divides into superficial and deep branches. The tibial nerve divides into the posterior tibial and sural nerves in the lower part of the leg. The posterior tibial nerve becomes superficial at the medial border of the Achilles tendon, near the artery, and the sural nerve emerges lateral to the Achilles tendon. So relative to the tibial artery is the posterior tibial nerve anterior or posterior. Typically what you find is that the tibial nerve is posterior to the artery. So you should be palpating for the tibial artery at the level of the medial malleolus and medial to the Achilles tendon prior to inserting your needle for a posterior tibial nerve block. Ultimately, blocking the posterior tibial nerve provides anesthesia to the heel and the plantar portion of the toes, as well as the sole of the foot and some of the motor branches in the same area. The sural nerve, again a branch of the tibial nerve, is located superficially between the lateral malleolus and the Achilles tendon on the opposite side, lateral side of the foot. Okay, and this block provides anesthesia to the lateral part of the foot and the lateral proximal aspect of the sole of the foot. So this image is worth 1,000 words here. You see the posterior aspect of the ankle and foot. Here's the Achilles tendon right here, and there is your tibial nerve, posterior tibial nerve, just posterior to the artery, as well as the medial malleolus. And here is your sural nerve, okay? And that courses down lateral to the Achilles tendon and medial to the lateral malleolus. So you can essentially deposit local anesthetic on each side of the Achilles tendon to capture both the nerves. The chance for vascular injection, of course, increases when you're trying to capture the tibial nerve here because of the posterior tibial artery. Question is the deep peroneal nerve blocked medial or lateral to the anterior tibial artery? So again, with the exam, you want to really know the arterial territory and venous territory of peripheral nerves in the attempts in your understanding of peripheral nerve blockade. Okay, so in this case, we're talking about deep peroneal and superficial peroneal nerve blocks and saphenous nerve blocks. Technically speaking, you can do a field block across the anterior aspect of the ankle and get all 3 of these nerves. It should work. These days, if you want to be a little bit cleaner about it, we use ultrasound guidance to identify these nerves individually. Okay, you can draw a line across the dorsum of the foot connecting the malleoli, the lateral and medial malleoli. The extensor hallucis longus tendon is identified by having the patient dorsiflex their great toe. The anterior tibial artery lies between this tendon and the tendon of the extensor digitorum longus. And you can identify the extensor digitorum by having them dorsiflex all of their toes. Okay. The needle is advanced perpendicular to a point just lateral to the pulsation between the two tendons on the intermalleolar line. okay? And you can inject local anesthetic deep to the extensor retinaculum to block the deep peroneal nerve, which anesthetizes the skin, a small area of skin between the first and second toes, and the short extensors of the toes. You can move laterally through the same skin wheel, okay, and that will ultimately block subcutaneously the superficial peroneal nerve, which will provide anesthesia for the dorsum of the foot, except for that small little area, that little patch between the first and second toe, which is covered by the deep peroneal. And then you can go in the medial direction to anesthetize the saphenous nerve, which is, of course, the terminal branch of the femoral nerve, which supplies a strip along the medial aspect of the foot. You can essentially put local anesthetic just anterior to the medial malleolus, and you'll almost always capture the saphenous nerve. So again, this image says a lot here. Here's your extensor retinaculum, and you want to be deep to that. In general, you want to deposit local anesthetic anterior to the lateral malleolus to capture the peroneal nerves. You get deeper and you'll identify the deep peroneal nerve, which will course down into that web space between toes number 1 and 2. And then, as I said, just anterior to the medial malleolus is where the saphenous nerve lives. You can do essentially a field block, as you see in this image here, to capture all three. Ankle block's pretty straightforward. You know, I have to admit, on my actual board exam, the very first question number 1, involved the ankle block. And I kid you not, they described a healthy patient who needed foot surgery. They didn't describe exactly what they're going to do with the foot surgically. And they say, which of the following terminal nerves is most important to anesthetize? You know, you can know all you want about the ankle block, you know, but I'm not aware that anesthesiologists only allocate 2 cc's of local because they only want to anesthetize one nerve out of all of the 5 that innervate the ankle and the foot because they want to conserve local anesthetic. We don't think that way, so I'm not sure why the ABA allows for weird questions like that. It's not as though you're just going to leave the patient hanging if you miss a nerve. You're going to go back in and redo the block. But they do ask weird questions like that, so just be aware. Don't get frustrated. A couple of slides on fat embolism and tourniquet physiology, so that's fresh in your mind. Fat embolism syndrome is a physiologic response to fat within the systemic circulation. It's actual adipose tissue. Clinical manifestations of fat embolism include respiratory, neurologic, hematologic, and cutaneous signs and symptoms. Okay, they can develop a cutaneous rash across their chest, develop respiratory insufficiency, neurologic deterioration, and they can go into DIC. The quantity of fat in the circulation doesn't necessarily correlate with the severity of the syndrome or the progression to ARDS. As I said, a petechial rash is pathognomonic for fat embolism syndrome, especially when you're doing operations on broken lower extremity bones, long bones which contain a lot of marrow and fat. Okay. So the neurologic manifestations include drowsiness and confusion all the way to coma. The CNS symptoms have developed in the absence of significant pulmonary complications and may represent the passage of fat droplets across a shunt or an atrial septal defect. The treatment of fat embolism is largely supportive. Okay, you have to resuscitate and manage their ventilation and hemodynamics. You may have to induce general anesthesia if the patient hasn't already been instituted with general anesthesia to minimize the impact of the neurologic manifestations and brain protect. Patients at risk for fat embolism syndrome should be monitored with pulse oximetry and should be tracheally intubated in the most severe cases. With tourniquets, a pneumatic tourniquet is routinely used in orthopedic surgery, of course, and that's to provide a bloodless field for the surgeons. Tourniquets are usually inflated to a pressure about 100 millimeters of mercury above the patient's systolic for 1 to 3 hours. Nerve injury after extended tourniquet inflation of greater than 2 hours has been attributed to the combined effects of ischemia and mechanical trauma, especially in the setting of pre-existing nerve injury or neuropraxis. Pain related to tourniquet inflation really starts to peak at around 60 minutes, despite the presence of a regional anesthetic that's adequate for surgery. It's been postulated that tourniquet pain is caused by the unblocking of unmyelinated C fibers during recession of a neuraxial block, as an example. The addition of opiates to spinal or epidural anesthesia may ameliorate tourniquet pain. It's pretty effective in that regard. And after tourniquet release, this is where you really want to focus your attention, not only clinically, but for the exam. The board expects you to know what happens when you inflate a tourniquet and deflate a tourniquet. When you inflate a tourniquet, you increase afterload on the heart because the heart's pumping against a higher arterial or constriction when you inflate that tourniquet. And of course, when you release it, you have an abrupt decrease in afterload, and you also have a return of circulation of blood that's been spent quite a bit of time undergoing anaerobic respiration. So you're going to get a lot of acid load and potassium, and you may see a dip in the patient's temperature because that blood is cold as it returns into circulation. Typically, you'll see sort of a wash-in of carbon dioxide on the end tidal CO2. This is pretty typical of tourniquet release. But the most significant thing to watch for, of course, is as the tourniquet's released, that debris, solid debris, and particulate matter may end up embolizing into the lungs, causing hypoxemia. So that's it for the regional series. We're going to have one more lecture in this, for just to cover and review some neuraxial anesthesia concepts and related to the advanced exam. Thanks for listening.